Hello, my name is Jacob Katsnelson. I'll be talking about regional pain blocks and perioperative pain control in patients undergoing breast implant removal with capsulectomy. The significance of this study is that more patients are undergoing breast implant removal with an increase of over 15% last year compared to the previous year based on the ASPSS statistics. Demand is steadily increasing due to patient safety concerns or symptoms they ascribe to their implants. The media reporting of breast implant illness syndrome likely is contributing to this. Additionally, more patients are requesting in-block capsulectomy. Pain control for these patients can be difficult due to increased scar tissue around the implant, the potential for extensive dissection with a capsulectomy. Ultrasound-guided regional pain blocks are a good adjunct available to the plastic surgeon. When properly performed, they can offer significant perioperative pain control in breast surgery patients, but the evidence to support a specific block is limited. Here we sought to assess the efficacy of several different regional pain blocks in this patient population. We conducted a single institution retrospective review. This was all patients who underwent breast implant removal with capsulectomy at our ambulatory surgical center from 2018 to 2020. These patients had a combination of 4 different ultrasound-guided regional blocks, as shown here. Serratus anterior block, erector spinae block, which is performed deep to the erector spinae muscle and superficial to the transverse process. Pectoralis 1 block, shown here by its ultrasound landmarks, or the pecto-intercostal fascial plane block. We then compared intraoperative, postoperative opioid requirements and also post-op day 1 pain reported by the patient. The results of our study show that there were 352 patients, 7.4% underwent a serratus anterior block, 3.7% underwent a PFIP block, and about 89% underwent a combination ES plus PEX1 block. Only 5.4% of patients required opioids intraoperatively by the anesthesiologist. 27.8% of patients required opioids in the recovery unit, and about 69% of patients reported very good pain control with no pain to mild pain on post-op day 1. That's a pain score of 0 to 5 on a scale of 0 to 10. The combination of ES plus PEX1 seemed to be associated with less intraoperative and postoperative opioid requirements compared to the other 2 block techniques. Additionally, ES plus PEX1 was associated with milder pain on post-op day 1 compared to the 2 other regional block techniques. We conclude that ultrasound-guided regional blocks do offer an effective pain control regimen for these patients who undergo breast implant removal with a capsulectomy, resulting in low perioperative opioid requirements and good patient-reported pain control. The technique combining erector spinae with a pectoralis 1 block appears to be superior to an isolated chest wall block in terms of opioid requirements. There's certainly several limitations to the study. We don't have a control group as all these patients received a regional block. The choice of incision could vary, though usually this was performed through the previous implant placement. The extent of capsulectomy varied, although most patients did have a total capsulectomy performed. There's a subjectivity bias in terms of post-op day 1 pain reporting and relatively short-term follow-up. I'd like to thank you for your attention to the study.